Three, two, one.
Hello, everyone. Um, I am so overjoyed to be a part of the MOA series of 52 weeks, 52 surgeries. And when I was thinking what to showcase in this particular segment, I thought let me take up an area which was self-learned by me completely on my patients with the help of several MOA members. And hence, that is the surgery which I have chosen for you all today. So CTV, as we know, is very, very rampant all across Maharashtra. And all of us are familiar with literally the kind of huge spectrum that we have to deal with, as you can see here, right? From postural, idiopathic to arthroplasmotics and severely neglected ones and syndromic children. And particularly so because we deal with a lot of patients from the regional belts that we encounter these kind of situations, the neglected ones and the rigid feet, very, very often. Despite the huge disparity and the difference in the way CTV presents to us, especially because of the rural-urban divide and the non-uniformity of the healthcare systems between private and public institutions to even camp-level surgery, poverty, lack of awareness, what this patient finally expects from you is somewhat like a juggler. You should be able to treat all varieties of CTV in all varieties of ways. And hence you have to have a lot of different kind of surgeries and methods in your armamentarium. So we are going to explore one such armamentarium which was exclusively developed in India and in Maharashtra by a very, very respected and doyen of a surgeon from Bombay. What is really happening in the world of CTV and the methods that have been followed all over the world are various, as you can see enlisted here. But now slowly, as the time from when I have become a postgraduate to when I have my own postgraduates now, some methods are really falling out of vogue and wisdom comes in hindsight. So what are we left with? Arthrodesis is virtually extinct. Home manipulation and strapping is given up. Open surgeries, osteotomies, stenotomies, all used to have a place, but that is also going away. Naviculectomies are virtually not heard of. What we're really left with in the Indian scenario as a common thing is plastering with Ponseti techniques or with their modifications, as many as orthopedic surgeons are there, those many modifications. But Ponseti is really swept the whole state and the world, really speaking. And the most unique thing amongst them is the fixators, which we are really left with. So it behooves every pediatric orthopedic surgeon to know how to apply a good fixator and use it, because applying fixator is just the first step. And if you actually think about it, it is an extended or a modified Ponseti in many, many ways, as we will see in the forthcoming video. So what was the concept of Ponseti? Let's just touch upon that to brush upon our thinking about fixators. Atraumatic remodeling of the bones and joints, utilizing the kinematic coupling and the interdependence of motion of the ankle, subtalar and tarsal joints, because the crins or the different kind of collagen allow a good correction. And this is precisely what the fixator does, that it addresses the deformity from without. It affects a change at one particular joint, and because of the interdependence, the other joint starts opening up, and therefore you get a very nice supple correction. So in Ponseti, if you're expected to go from inversion to gradual abduction and outwards eversion, and then an unlocking of the talus and going on to a full correction, that is exactly what will happen in the fixator. And you will see on the skeletal model, as I show you here, that this is how we tackle at every adjustment of the fixator, and we keep bringing the foot out in abduction like this. And therefore, with the interdependence and kinematic coupling, the heel moves from a varus neutral to a valgus and eversion. So where are we poised in terms of CTV treatment now? You have to be able to treat antenatally. You have to be able to treat the young toddler with CTV. All this can be done with plasters. But when you are dealing with their fathers and parents who now come to you because they are motivated, since you've corrected the child's foot, you will have to use the magic of the external fixator or the JESS. And one shoe size is not going to fit all, so you're going to have to customize your treatment depending on the rigidity of the foot. It may be a little bit of a roller coaster ride. There is a learning curve, but if you are really dedicated, you can use the fixators to the best of your advantage. I'm not much of an Elizaro person. I prefer to do more of JESS. So what was JESS distraction really? The principle was controlled differential distraction, originally described by Dr. B.B. Joshi way before 90s, but he started writing about it and formalizing it in the 1990s. It differs from the classical Elizaro in significant aspects. Number one, we don't use axially tensioned wires at all. The frame is unconstrained. Differential distraction is used to correct the deformity, and the frame essentially has to be unconstrained so that you're able to mold and modify depending on the need of your patient, and hence this is the most modular system to my mind. The UX is just a modification of it. In the coming video, I may have used that, but essentially it is the JESS that we are dealing with. So what is it? It's equivalent to you becoming a Bahubali and being able to address all three deformities at the same time if you really polish your skills well. Clubfoot is a multi-apical deformity. The apices, as you can see very clearly here, are in the tibia, in the ankle joint, and the forefoot. And hence, each is at a different plane, and it is very difficult to pinpoint the precise cora. Hence, the frame must be unconstrained. And that since the child's foot is largely cartilaginous, you don't want a tight compression or a tensioning at any of the joints. You are going to use differential distraction, which means more distraction on the side which requires it or which is more rigid. And this therefore avoids compression and the crushing of the bones that generally tends to happen with other fixators or methods. How do we use a differential distraction? As you can see in the picture here, the rate of distraction on the concavity is double the rate of distraction on the convexity. If this is 1 times 1x, this is going to be 2x times of distraction or turning of the turnbuckles. What are the principles? You basically use K wires to achieve skeletal hold in each of the components. That's your tibial part, that's your heel, and that's your forefoot. And you have a separate assembly in each region, which you then pair off and square in the end. The forefoot assembly, as you can see here very clearly in the metacarpals, the hind foot assembly, as you can see here, and the leg assembly shown on the model. The procedure is simple, universally followable at any small nursing home, district hospital, teaching hospital, or a big multi-speciality hospital. The forefoot system then is, and the hind foot is paired with distractors. Those are the foot distractors that you can see here. And those are the equinus distractors, and the whole frame is squared off. This is just done in the end once you have almost finished the procedure. How does it work? You do a manual derotation where the linear distraction stretches the soft tissues gradually. A weekly readjustment of the frame if the child allows it in the OPD, or if it's an adult that you're dealing with, certainly he will allow it. The squaring of the assembly then achieves a derotation of the calcaneus, as I will show you in the forthcoming animation. Every 15 days or 3 weeks, you can take the patient under anesthesia or light sedation. Distractors are detached away, and the frame is derotated manually to give the abduction, and then the distractors are reapplied, and the whole system is tensioned again. And the collagen links, which you develop like this, they take 4 to 6 weeks to mature, and you must leave it on a holding mode after the correction is achieved, because then the frame retains the correction better. And all these points are important before we go on to see the actual video, because the first step is doing the fixator, but understanding the process is the more important part. So now let's look at this animation video and see how, with gradual distraction, what you're going to do here. The lateral distractors 1/4 for 2 times a day, 1x times, and the medial distractors 4 times a day. If I may just take you back a little and show you the same thing again. Please observe the lateral distractors 1/4 turn a day and medial 4 times a day. Then you have derotated, manually taken off the distractors and actually achieved abduction. Again, you keep on distracting with the same rhythm. Again, after 15 days, take off the distractors under GA, abduct a little more, and there it comes into neutral alignment. Again, another 15 days, keep the frame on, distract again. It opens up the cavus also. And when you take off the distractors, this time you achieve a beautiful derotation of the talus into the ankle mortise, as seen over here. Reapply your squared assembly, and voila, you have the correction right in front of your eyes. Let's now look at it on table, how to do the basic first step of the process. This is a rigid ctev. A 3-year-old who was basically suffering from a syndrome, had several surgeries, as you can see there. That's the X-ray of the same child. You can very clearly see the crushing of the bones that had happened with the several manipulations and the failed surgery. And there's a severe varus there. There is a midfoot inversion. The Pirani score is virtually 6 by 6, and the heel is in severe equinus. We now move on to see even the lateral views of the same patient. There you can see again a very, very rigid equinus, a virtually flat top talus which is completely out of the ankle mortise there, and a very, very deep cavus. So the exact components which the the Ponseti system addresses, we are going to do the same with our fixator technique here. Let's go on now with the rest of the video. What components do you need on table? Let's understand this a little bit. So I'm going to pause the video a bit. You need several lengths of straight connecting rods. The longest ones are going to be used for squaring the assembly. The shorter ones are going to use for squaring the paired distractors in the foot. And the slightly longer ones, as you can see over here, are used for the equinus hold. You need Z rods of multiple sizes. You need L rods of multiple sizes. You need a set of Allen keys, and you need 2 similar distractors for the foot of the same size. It always helps to keep a couple of additional ones more also, because particularly if you're dealing with a very rigid deformity, sometimes you find that applying the distractor is not always that easy, and hence couple of sizes on each side, if you keep extra on table, always helps. And you need 2 more big rigid distractors for the equinus, and of course your normal routine dressings on the trolley. You don't require very complicated instrumentation. Your drill and K-wires are fine. When we learned it with hand drills, and I still prefer to do it with the same because it helps in giving some particular motion. I'm sorry, let's go back to the video again. Yes, so we are back on. Let's start. Okay, so we have armamented. These are the clamps which are very, very needed. You must keep each of these clamps open before you start. When you are doing the first part, it is important to have the child in supine position. With the dot, I have marked out here the entry point of the first calcaneal pin. And this is really important to understand because you need to hit the midline of the calcaneum bone. And the longitudinal calcaneal axis is a little bit off center, as we can see out here. A simple way of detecting that actually sometimes is just using your K-wires and positioning it first out on the outside, as you can see here, and taking a shoot and confirming your axis, and then you simply drill across this in the same way. A good way of confirming whether you have drilled well, go only halfway through, is by moving the K-wire side to side, and if the whole foot swings along with it, then you know you are in the correct plane. Next, you drill across from medial to lateral with a simple K-wire with a hand drill, keeping the posterior tibial pulse intact, and go from medial to lateral, so there are very less chances of neurovascular damage. Let me come back again to the video. Yes, we are good to go again. So that's your confirming your transcalcaneal axis, confirming your position, and drilling from medial to lateral. Once that is done, over drill a little bit so that you have some place. Put your two L rods on either side, drill two wires in the same position. Make sure that all three of these are in the collinear direction. Next, you come to your foot frame, go from the little finger to the great toe and put two K wires there. Make sure that again this also has L rods. One of them can be transfixing all across. The other one you can just use half pins, which is the more proximal segment of the wires. Put your L rods on and you can now start applying your foot frame distractors. Make sure that the mouth of these faces downwards so that when in the ward that you can just simply ask the child to raise up the foot and you can retighten your clamps if needed. I'm sorry, the video keeps jumping. I shall just come back to it in a brief second. Give me a moment, please. I will be there again. Yes. Now we are again back on the same step, going from lateral to medial. The K wire is being drilled. There's a better chance of hitting the bone if you go from lateral to medial rather than medial to lateral, and that's your foot frame done. So once you have your hind foot and foot frame done like this, as you can see over here, it's simply a matter of connecting both your medial and lateral distractors, and then you move on to doing the equinus assembly. Identify the tibial tuberosity as shown here. Again, go from lateral to medial in order to avoid damage to the lateral popliteal nerve. Use the hand drill like a T-chuck, as I did in the beginning, and then drill across the two wires. Make sure that both of them are parallel to each other. Attach your Z rods onto them. After having done the Z rods, please make sure that you release the tension on the skin as is shown over here. On either side, once you have the Z rods also parallel, you can simply reattach all the distractors on it. While attaching the distractors, you must open the mouths of all the clamps, and this is how after the connecting rods, the entire equinus distractor goes on. As you can see, the hind foot assembly has those additional wires, and now the forefoot assembly also has this frame. And this is the final look. Once you have done that, tighten the whole frame and put your medial tibial pin also, and that's the final frame how it should look. And you will dress it up. Keep the deformity, that's the foot end view of the same thing. Make sure there's enough distance between the wires and the frame and the foot so that there is no impinging and pressure source state. And then you start your lateral distraction 4 times a day and immediate distraction 4 times a day and your lateral distraction 2 times a day. For those of you who want a continuous view, I'm just replaying the entire video because as I was explaining the steps, I kept stopping and therefore you all had those difficulties. But now you can really recap the whole picture. A 3-year-old rigid ctev which was syndromic, operated and recurred, very severe equinus, very deep cavus, and that's the armamentarium that you require. Very, very simple instrumentation and just a drill and K-wires and a few clamps, good Allen keys, a good assistant, good positioning, and I'm sure every orthopedic surgeon can do this procedure well, provided you follow each and every step to the T. So that's the surgical procedure, the transcalcaneal axis. Making sure and confirming that you go only up to the calcaneum, don't go into the joint. Have a good hold on the hind foot. Drill your K-wires from medial to lateral in the calcaneum, keeping it parallel to each other and perpendicular to the transcalcaneal pin first, attaching the L rods with clamps and tightening them, and then going on to the forefoot assembly, going from the little toe to the great toe, putting one transfixing pin as you can see over there, which is happening here right now, then 2 half pins, putting L rods on them, and distractors connecting the hind foot to the forefoot, and that's your foot assembly complete. with a transverse connecting rod as well. And then go on now to the leg assembly, where you will identify the tibial tuberosity first. This child, you can notice a scar of the CDK surgery also. And first use your drill like a T-chuck so that you enter the tibia without damaging the lateral peroneal nerve. And then drill across, making sure that both the K-wires of the leg assembly are parallel to each other. After which you will put Z rods again, relax the skin tension at every interface where the K-wire is near the skin, as well as attaching the straight rods to it, making sure that your Z rods are parallel and perpendicular to each other, opening out each of the clamps, and then finally attaching them as the equinus distractor. While doing this, sometimes you may have to use a little bit of manipulation and correction of the deformity, but which is pretty much justified. The medial side is usually easier to apply than the lateral side, because the lateral side is still very much on the long axis of the concavity. And then tightening the leg frame and passing the half unicortical tibial pin and the final squaring of the assembly. And that's the foot end view of the same thing. And you're dressing regularly and understanding the distraction and teaching the parents is equally important. Make sure that you do it 2-3 times with them so that they follow you through. The collagen links take 4 to 6 weeks to mature, and hence if you have taken about 4 to 6 weeks for the whole correction, then use the same period to keep it in holding mode so that you don't get a rebound phenomena and the deformity doesn't recover all over again. Some clinical examples: a child with an Escobar syndrome with an extremely rigid ctev, you can virtually see that the tibia and talus are literally in the same axis over there. This was beautifully corrected with the frame, and after which he hardly needed only tenotomies, and this was very easy for him later on. Then we went ahead with the scoliosis correction. Yet another 2-year-old child, just completely neglected. You can see the x-rays over there, kept in a frame that was his equinus earlier, and then both legs were done simultaneously, one by one finished correction a little earlier, so we put him in a plaster, and that's the beautiful correction that we got later. And that's the kind of supple feet that you get. The foot size remains equivalent. That's the dorsiflexion and the plantar flexion ranges. So you can see how beautifully supple these children remain by using a JESS. Even after surgery, they can get a very good range. Again, he was neglected and recurred following a PMR. That you can even see the relaxing incision there. So that just gives you an idea of how beautifully the correction is achieved with the JESS. How old can you operate? Well, I've done cases almost up to 14 to 16 years of age. That's again that walking ctev was virtually walking on the dorsum of his foot. The JESS frame applied, corrected in 6 weeks, completely straight. And you can see that his operative scar had also stretched out very well, and he was walking very, very nicely. So with this juncture, I will now stop, since this is only about the video technique and the technique itself, but there's lots and lots more awaiting you, especially regarding the neglected clubfoot and many, many other topics of the general orthopedic surgeon's interest as well as the pediatric orthopedic surgeon's interest. We have kept 25+5 mini modules on focus topics so that you can threadbare discuss to your heart's content with the best of foreign faculty. And each delegate can avail of 10 ICLs of his and her choice. They will be held in adjacent halls. There is no special cutoff of as to where you can sit in which ICL. So you can actually avail of all the ICLs if you wish, whatever nuggets of wisdom you can imbibe from each of them. That is the world-class faculty that we have gathered from all across the globe. And I don't think you would have any higher subject experts in most of these specialities. It is really a dream team which is coming to teach us together in the Silver Jubilee Posicon. The program has been catered to suit. Everybody will find something or the other to do in this. Plus, we have 2 unique master classes. For the first time outside USA, the Drawer Ballet course is being held, so don't miss this opportunity. And for all you spine lovers, the God of Spine is coming, Newton, on which we have a unique master class. When you talk of God of Spine and you have the God of Cricket, he can't be left far behind. So for a world-class faculty, we have a world-class chief guest to match who will be at the inaugural function. Don't miss the chance to see him in flesh and blood. and scintillating 3 nights of entertainment, a shining star contest for the first time. Rush in your entries. This is open to registered delegates only. And a very, very offbeat entertainment on the other 3 days. Several first-time features like a jugalbandi between two ortho bands, a shadow act performance, ventriloquism, and a mela. I think there is lots and lots to look forward to in the Silver Jubilee PosiCon, and it's my duty as the organizing secretary to invite you very, very warmly between the 3rd to 6th of January 2019 at the Renaissance Mumbai Convention Center. Do join us to learn more about the JESS, the neglected CPP, and much more. Thank you.